Dear Professor Dr. Leyla Özer, who is an eminent medical oncolog in Memorial Bahçelievler, thank you very much for accepting us.
Thank you. It's my pleasure, really.
First of all, I would like to ask, does the family history of having cancer increase the risk for patients?
Generally speaking, indeed, really having a member diagnosed with cancer in the family may increase your cancer risk generally. But of course, there are some disorders, main specific cancer types, which we know that are really linked to some hereditary disorders. We should maybe first just explain what we mean by hereditary disorders. That means you transmit the mutated gene to your offspring, to your child, so that it is over there when you are born. And you have the risk to develop a cancer just starting from the day you are born into life. But of course, I can say that all cancers are indeed genetic disorders. This happens due to some dysregulation or some alterations in our genes. But only 5% of the cancers, I can say, are hereditary. They are transmitted from father or mother to son or daughter. But the rest always occurs due to some changes in our genes, but these are mainly due to some environmental causes, but also some endogenous things like hormones and peptides, the way you live, the diet, exercise, alcohol, smoking, everything may cause a change in your genes, and then your normal healthy cells may become as tumor cells.
So, when you mean hereditary, what type of cancers are more in that field? You can name them, or is it wrong to state such a
No, I
wording?
think it's quite important to create this awareness indeed. The social media is very acquaintance to this breast cancer related BRCA gene related cancers, which mainly presents itself as breast cancer or ovarian cancer. But apart from these two cancers, for example, these BRCA gene related cancers are, for example, pancreatic cancer. You may have a risk of increased prostate cancer and some peritoneal cancers, which are indeed embryologically totally very similar to the ovarian cancers, but you may not have an evident mass in your ovaries, but you have the cancer in the peritoneum, which is the layer that is in the abdomen and lying over the intestines and every structure in the abdomen. So BRCA gene is one of the main genes that we are searching for when a patient with breast cancer arrives into our clinic. Of course, not only having breast cancer may just search us to go with BRCA gene disorders, but if you have a family member also having these BRCA gene related disorders, such as I had mentioned, ovarian cancer, bilateral breast cancer, having a male breast cancer in the family, and prostate cancer, pancreatic cancer, all are these can be related with BRCA gene. But what I'm trying to emphasize, especially these days, is that we have other hereditary cancer syndromes, such as hereditary gastric cancer, for example, which is, I think, sometimes overlooked, but I think it's quite common in Turkey. But it's important to recognize it and to search for it. This is a specific type of gastric cancer. You may have a few members in the family, but you may be the first one in the family having this disorder. If you are having a gastric cancer earlier than 40 years of age, if your histological subtype of the gastric cancer is diffuse type, or mainly known as signet ring cell type, then we should keep in mind that this might be an hereditary disorder. Even though you are the first one in the family having this cancer, you still should be looked for having whether you have a mutation in your CDH1 gene, which is related to disorder. What it means, we know when we have a BRCA gene related breast cancer, we always search the whole family members and everybody is recognized, and then if you have this disorder, we talk about whether going through a mastectomy or oophorectomy, removal of the ovaries, just prophylactically, even when you do not have cancer over there. When you have this hereditary gastric cancer gene, for example, we should really discuss with these patients or the family members to go through very early endoscopic evaluation. Previously we were also discussing prophylactic gastrectomy, but of course having a gastrectomy, removal of the stomach before it gets cancer, is a serious discussion and decision. Yeah, that's why serial and very aggressive evaluation of the endoscopic evaluations are quite important in such families. But of course, there are various hereditary cancer disorders like Lynch syndrome, for example, which is related with uterine cancer, breast cancer, colon cancer, some renal or kidney cancers, and this is one of the most common seen hereditary cancer disorder.
So, and then for the genetic tests that are applicable in Turkey, which type of patients can use these tests, which is offered for international patients in Turkey?
Well, as I had mentioned initially, breast cancer patients earlier than 50 years of age, those with triple negative breast cancer, those with a huge family history in their family, having cancer, those with young gastric cancers, and even I should say all the endometrium cancer patients should undergo this hereditary gene testing. This is a recommendation based on the guidelines indeed, because it might be really quite frequently linked to this Lynch syndrome, and endometrial cancer is one of the most frequently seen cancer type within this Lynch syndrome. This is another cancer-related syndromes. And also, if you are having a locally advanced or a metastatic colorectal cancer, still also we offer such patients hereditary evaluation. Indeed, there are different panels for looking these genes. You may have just a limited number of genes included in your test, so you can go through just very frequently seen cancer syndromes. But of course, you can make a more detailed genetic analysis, which are made from blood. This is just for hereditary testing, I should mention, because this is something totally different that we use the genetic test while making some decisions about therapy for a patient who has already been diagnosed with cancer. But if we are just trying to search whether this is something hereditary or not, we have some short panel gene tests or sometimes more broader genetic tests where we can search for rarer hereditary cancer syndromes.
So what I understand is that the generally now medical oncology is much more personalized.
Exactly, yeah.
And there is somehow a kind of roadmap for each and every patient. This is what I understand from your framing.
Yeah.
And then also then some of the patients are addressed by smart medicine and immunotherapy, which you have been mentioning. So how you are addressing such kind of patients, international patients, for these different therapies?
Well, hereditary cancer testing is something different, which we are trying to find out the risk for the family members, but also it sometimes gives information about the drugs that we should use for that specific patient. But if you have an already established cancer diagnosis, which patients should undergo, we call it somatic testing. That means test made from the tissue, the cancer tissue. Indeed, now the guidelines, 5 years ago or 10 years ago, they were just offering to do these tests only for advanced diseases. If you have a stage 4 disease, it will be good to have this genetic profiling of the tumor. But we know that now, even in the early disease setting, it is really quite useful to understand the behavior of the disease. And also we know that some of the targeted therapies right now, or the immunotherapies, are used even in the earlier disease setting. And that's why in order to decide about the drug that we should use, we are trying to just see the result of these tests before the disease gets advanced. And also we prefer to do such testing during the course of the disease. Okay, you have first a molecular profile, you just take a screenshot of the disease and you start some drugs, and in time you may have progression. And you should understand the mechanism of progression to decide about which way to go, which drug to use. if you have something to overcome this resistance, then you would go from that way. And in that time point, we may do again the tissue biopsy. This is a solid tumor tissue biopsy, or we call liquid biopsy. You draw some blood from the patient and you search for the tumor DNA from that blood, shed into the blood, and then you can just search for the resistance genes from that blood specimen. So we can do this resistance evaluation both with solid biopsy, but also we call liquid biopsy, or just from a blood test.
So in every stage almost you are again and again mapping the disease based on the patient, general framing, each one for each and every patient.
Certainly.
And what can you say about the side effects about such personalized smart medicine and immunotherapy sessions, especially when you are a patient coming from your home country and trying to seek a treatment in another country.
Sure.
So you are a very experienced doctor. What you can say about it for the patient and the family, maybe?
Well, of course, it depends on the drug that you use, that the disease type, the stage of the disease. We are always trying to give the precise information, all the details about what type of side effects we can encounter with such drugs, especially about the targeted therapies. Although they are called smart drugs, they are not sometimes as smart, and so they may have some off-target side effects, which is, they may have some, again, damage to the healthy cells, which are usually reversible side effects. Of course, we inform every patient about such possibilities. And I think that although the patient comes from abroad, I think the way we do in our clinic is from the very beginning, we try to be always in close contact with the patient. At least myself, this is my way of attitude indeed. I try to just give my phone number to text whenever there is a problem, and we try to be always in touch through email. Also, we are also in good collaboration with some of the medical oncologists in different countries, and so we can contact each other, and it's really much better way to handle the situations when the patient is outside. I can understand the patient's concerns when they get the therapy here and have some problems over there. Of course, it's not an easy situation, but I think being in close contact with the patient and relatives, and detailed informed consent from the very beginning, and also good collaboration with the other medical oncologists over there will be a solution for such problems.
Yes, I have experience with yourself or one of my Romanian patients that you had the family contacted you through an online consultation.
Yeah.
What you can say, actually after COVID it was more and more used.
Exactly.
What you can say about your support for patients as an online consultation method? Do you use it? It benefits the international patient. What you can say?
Of course, face-to-face is something different,
yes.
But as you have mentioned, after the COVID, we are getting quite used to doing this in that way, and it's really important to see the patient. We are doing this very frequently during the last 5 years.
Yes.
If you have the data from the patient, if you see the patient, although it's an online setting, you just ask the questions, you just get the impression about the performance of the patient. And of course, it's not completely like seeing and touching the patient. I think it's quite important, although I'm just making it aside. We have many patients that we are on follow-up in this way.
It can be just maybe a basic clarification
Exactly.
from the doctor herself or himself to the patient and the family, which is more than wording and writing.
Exactly.
Just in their decision-making process. And finally, what I would like to ask that, what you can say about the early diagnosis helping your treatment for gastrointestinal cancers? You're an expert on this. What you can say about it?
Yeah, thank you very much for this specific question, because I think it's quite important to emphasize that regular colonoscopic evaluation
yes.
is one of the recommended basic screening methods for cancer, and it's always overlooked. Why? Because colonoscopy is not something that is very sympathetic for most of the patients. But we know that this is preventable disease, I mean colorectal cancers. If you are undergoing a regular colonoscopic evaluation, then this disease can be diagnosed in the very early setting from when it's a polyp already over there, no cancer cells. But if polyp is removed, then the disease is totally gone. But if you are not undergoing a regular colonoscopic evaluation, then in time, this is something quite established, this information. I mean, if you do not remove that polyp over there, in 5 to 10 years, you will have the cancer, okay? So although it is not a very easy way of screening compared with some going through mammography, doing some cervical smear, I think most of the population has already got used to this, but colonoscopy is still just blank over there. We know that from the, published data, only 60% of the population, the target population, is undergoing colonoscopic regular evaluation, even in developed countries. And it's quite rare also in countries like developing, in our city, for example. So I know that screening for gastric cancer is not a recommended, guideline recommended screening test for the moment, but especially countries like us, having salted, smoked food habits, gastric cancer is quite more frequently seen compared with other parts of the world. And that's why I usually tell my patients, if you're going through a colonoscopy, do the gastroscopy also. Although this is not I'm again emphasizing, it's not a guideline-based recommendation, but in Japanese, for example, in Asian countries, this is one of the screening methods.
Very important. And how old, for women, what age? And for men, what age do you recommend?
Very important question again. You are quite, I think, updated with the data, because previously it was 50 years of age. And according to the cancer statistics data, we saw that the number one cause of cancer-related death for patients under 50 years of age is colorectal cancer. And generally speaking, the first one is normally lung cancer, generally. But for younger patients, smaller than 50 years of age, we know that colorectal cancer is the leading cause of death. And it is the only cancer that is increasing during the last 5 to 10 years. And that's why most of the guidelines are now recommending to do this colonoscopic evaluation before 45 years of age. After 45 years of age. And also, if you have a member in the family with colon or rectal cancer, I think it is better to start this screening 10 years before that patient is diagnosed. So if the patient is diagnosed at, for example, 45 years of age, then the close family members, I think, should do it 10 years before it, starting from the 35 years of age. If you have a huge family sequestration regarding these cancers, because sometimes you cannot really find a genetic disorder, even you have a strong family history, then it is important to identify the youngest patient in the family and to start especially colorectal cancer screening 10 years before that age.
Yeah, very, very important, valuable information from one of the most eminent oncologists.
Thank you very much.
Thank you very much for your support,
My
for
pleasure.
your international patients.
Thank you.